So this big push towards population health is going to require a new way of thinking about the electronic health record. And so instead of just being a record of what's happened, it's got to be more of a plan and helping physicians and patients stick to that plan. So the first thing you'll have is everyone will have a foundation plan. And depending on where you start, so a healthy young man like myself would maybe have get his cholesterol screening every 5 years and try to encourage him to exercise regularly and eat right. A person that's 85 years old with multiple comorbid conditions might be told to take a statin for their heart, take some blood pressure medications, try to exercise and eat right, as well as get a flu shot every fall, and so their plan would be much more complex. And so those foundation plans will change over the course of the life of a patient. And these plans will be a combination of medical strategies, both with the public health. So, for example, the vaccination schedule will be part of these plans. And then on top of those foundational plans will be these transient plans. And so this is the case where, for example, if I get a cold this fall or it turns into pneumonia and I have to go into the hospital, there'll be a special plan that'll deal with my pneumonia while I'm in the hospital. Or if I break my ankle, there'll be a transient plan of getting that ankle fixed and doing the rehab that'll layer on top of that foundational plan. And then these plans should be based on the best available clinical evidence. And so the question is, how are we going to bring the evidence right into the electronic health record to try to help the clinicians understand why we're doing these things? And then for each group of patients that are on a similar plan, so for example, I told you about the healthy male plan or the elderly frail plan, those people form a population, and all those people can be managed together, and we can get statistics on them and think about how they'll work together. And then we measure risk, which will be the likelihood that either I don't engage with my plan, that means refusing to exercise or eat right, or the other person that refuses to take their statins, or the likelihood that I get sicker and can't maintain my plan. And so that'll be the risk. And then you've got to remember that not all care is going to be amenable to these predefined plans, because there's always things that are going to be coming up. And so the electronic health record is going to be able to do the sort of these common foundation plans, the transient plans, and then these emergency things that no one ever expected.